My dear students, a very warm welcome to you. Welcome to the next pharmacology session, the new session on pharmacology. We are doing various sessions on chemotherapy. We've discussed various antimicrobial agents. We're discussing the chemotherapy of individual illnesses. And on this session, we are starting the discussion for tuberculosis and anti-tuberculosis agents. Mycobacterium tuberculosis is an acid-fast bacillus. And tuberculosis has been a very important illness in the history of medicine. What's the problem in treating tuberculosis? Look at the slide. It's showing you one by one the various problems and the various salient features. The organism is a slowly growing organism, a slow growing organism. And I hope you know, if the organism is multiplying rapidly, it's easier to inhibit the organism. If some activity is going on in the organism, some metabolic reaction, some metabolic step is going on, it's easy for your drug to go and interfere with a particular step. If the organism is slow growing, killing the organism becomes more difficult. Secondly, the organism is intracellular. So your drug has to penetrate inside the cell and then get to the microorganism and affect the microorganism. Next one, the Mycobacterium tuberculosis has got a lipid-rich cell wall, so that your drug should have the capacity to penetrate this lipid-rich cell wall. Next, very typical thing observed is, if you use a single agent, a single drug against tuberculosis, the organisms very rapidly learn to develop resistance against your single agent. So you can't rely on one single drug to be used for tuberculosis, and this is why you have to use many drugs together. And when you use many drugs together, you also have to keep in your mind the various adverse effects that the patient is going to face. Plus, it's going to increase the cost of therapy. The next important thing is, the organisms which are easily accessible will be killed, will be inhibited. But Mycobacterium tuberculosis goes to the deeper tissue cavities, and your drugs cannot reach there, may not reach there, and the organisms might persist. So they are called as persisters. So persisters is the next problem in treating tuberculosis. The penetration of the drug many times becomes difficult where the organisms are residing. That's the next problem. And nowadays we are getting multi-drug resistant Mycobacterium tuberculosis. That's the greatest issue, and the whole world and the scientists are dealing with this particular issue of multi-drug resistant microorganisms. Lastly, the last line on the slide is saying HIV, tuberculosis, about which once we were feeling that we've conquered this particular disease. After the advent of HIV, tuberculosis came in with a great force, and tuberculosis becomes one of the most opportunistic infections if the patient is suffering from HIV disease. So again, the battle against tuberculosis is on. Let's go on to discuss what are the drugs which you can use against tuberculosis on the next slide. What is the first line drug and what is the second line drug? This is a very common terminology as far as anti-tuberculosis drugs are concerned. The first line drug is supposed to be the standard drug therapy. The list of drugs or the names of drugs which are supposed to be standard drugs for tuberculosis. What do you mean by standard? Standard means these drugs are essential. These drugs are most commonly used. These drugs are most beneficial. These drugs are most effective, most active. Then you call it a first line drug, and naturally you choose from the first line agents in the first place. What's the second line drugs? Second line drugs are generally the reserve drugs. So you're not going to choose from this particular chunk immediately. You're going to try the first line drugs. If the organism doesn't respond, if the patient doesn't tolerate the drug, or for some other reasons, you can think of picking up a drug from the list of the second line drugs. The older drugs which were used for tuberculosis have become now outdated. We will keep in this second line drugs because no one knows at what particular point in time, again, the microorganism might start responding to the older agents. At the same time, the drugs which are under investigations, which are new, about which we don't know much, and they are likely to have the potential to be useful, also will be there in the second line agents. So that's the concept of what is first line and what is second line. Second line in general are less commonly used, and the first line are the most commonly used agents. Let's go to the next slide to see the first line and the second line agents. The only difference is I'm not just saying first line, second line. I'm also dividing them into bactericidal drugs and bacteriostatic drugs. So now you get 4 groups: the bactericidal drugs, which are first line and which are second line, and the bacteriostatic drugs, which are first line and second line. Let's have a look at the first row, that's cidal drug, first line, 4 important drugs: rifampin, isoniazid, that's INH, streptomycin, an aminoglycoside, and pyrazinamide. These 4 are the cidal drugs. They are considered the first line drugs. Straightway go down in the same column. The first line static drug is called ethambutol. So you always need to know about at least about these 5 agents, which are the first line agents. We go to the second column now, the third column, in fact, the last column, which is showing the second line drugs. And the second line cidal drugs are, there's a big list of drugs. It contains quinolones in the form of levofloxacin, ofloxacin, and ciprofloxacin. Then aminoglycosides, they are amikacin, kanamycin, and capreomycin. Next on the list is a group of rifamycins. It includes rifabutin and rifapentin. The next on the list you have macrolide group of antibiotics, that's clarithromycin and azithromycin. And there is one more agent which is a second line agent, cidal, is called linezolid. So that's about the second line drugs. You're not going to remember all the drugs instantly, just in one vision. When we'll discuss about them more, you are going to remember. The second line drugs, static, we have cycloserine, we have para-aminosalicylic acid, that's PAS. We have clofazimine. Clofazimine is an anti-leprosy agent which is useful in tuberculosis. Then there is ethionamide, which also is used in leprosy and in tuberculosis. And the last one in blue letters is thiacetazone. Thiacetazone is used in many countries as a second line static agent. So that's about the first line and second line. Once again I remind you, first line cidal, rifampin, isoniazid, streptomycin and pyrazinamide, and first line static is ethambutol. Let's move to the next slide. The next slide is showing you the standard doses of all the first line drugs. Rifampin, please remember the standard dose is 600 milligrams for the adult. Want in terms of milligrams per kilogram body weight, it would become 10 milligrams per kilogram body weight. INH or isoniazid, the standard dose is 300 milligrams. In terms of body weight, it's 5 milligrams per kilogram body weight. Pyrazinamide, 1.5 grams is the standard dose. It becomes 25 milligrams per kilogram body weight. Streptomycin is 1 gram, so it's 15 milligrams per kilogram body weight. And the last one, the static drug, that's ethambutol, also is 1 gram, and that's 15 milligram per kilogram body weight. If you want to remember in terms of milligram per kilogram body weight, and if you keep the sequence constant, it would become 10, 5, 25, 15, 15. 10, 5, 25, 15, 15. I hope you'll be able to remember this. Go to the next slide. The cidal and static drugs are shown here, which are second line agents. The second line agents include the fluoroquinolones, that's levofloxacin, is used in the dose of 500 milligrams every day. Aminoglycosides, important one is amikacin and sometimes capreomycin, 15 milligrams per kilogram body weight. The two rifamycins, rifabutin and rifapentin, in the dose of rifabutin in the dose of 300 milligrams every day, and rifapentin 600 milligrams once a week or twice a week. Next, macrolides, clarithromycin 500 milligrams 2 times a day, and azithromycin has got a long half-life, so 500 milligrams just every day. Next we come to the second line static drugs. So there's a least chance that you will pick up from this. There is cycloserine, 500 milligrams to 1 gram. Para-amino salicylic acid, which was used once upon a time, but we have kept it in the second line drugs. That's 8 to 12 grams. Ethionamide, 500 to 750 milligrams. Clofazimine, 200 milligrams. And thiacetazone, 150 milligrams. I have underlined it because this is the drug which is fairly commonly used between the static second line drugs. So you need to remember thiacetazone, 150 milligrams. Let's move forwards and start the discussion of individual anti-tuberculosis agents. Have a look at this slide. What I have done very typically for this particular chapter is the title of the slide is kept constant as long as we are discussing that one agent. So if you look at the title of the slide, you again immediately for each slide you understand and you come to know what are the special characteristics of this drug. For example, here the title writes so many things. Isoniazid, it writes it is cidal, then it writes CNS. You need to understand what I have written. Means it's got good penetration in the central nervous system. That's an important issue. Next, I have written intracellular. It means the drug can penetrate within the cell and can kill the microorganism. We saw in the beginning that the microorganism is inside the cell. So whether your drug is able to penetrate and go inside the cell is going to be important. So I'm writing intracellular. Then I'm writing the dose once again, 300 milligrams per day. That's 5 milligrams per kilogram body weight. Next item I'm writing prophylaxis. Means isoniazid can be used for prophylaxis. And the next line I'm writing, it's less for atypical. It's got less action against the atypical mycobacteria. So in one title you can understand so many things, so many facts about the single agent. So let me say it again. Isoniazid is a bactericidal agent, has got good penetration in the CNS, has got good intracellular penetration, is used in the dose of 300 milligrams, is useful for prophylaxis of tuberculosis, and has got comparatively less action against the atypical organism. Remember, we are discussing a very useful and important agent for tuberculosis, and that's isoniazid. Let's go further to discuss isoniazid in detail. When isoniazid goes inside the body, it goes to the tubercle bacillus, it needs to get activated by the catalase peroxidase system. The microorganism has a catalase peroxidase system. This system needs to activate isoniazid. So once while discussing about metronidazole, I remember I had said the drug is very wise. It goes inside the microorganism, uses the source of the microorganism for taking some enzymes, and itself gets activated. So INH is same, gets activated by the catalase peroxidase system. This catalase peroxidase system is encoded by a gene called CAT-G gene because it's catalase peroxidase. The name is starting as KAT capital G. This gene, which encodes for catalase peroxidase system, is called CAT-G gene. The drug forms covalent complexes with the acyl carrier protein, that's called ACPM, and beta ketoacyl carrier protein synthetase, and that's called KASA. So this is how it will form the covalent complexes, and with all this is going to inhibit the cell wall synthesis. The cell wall in the mycobacteria is composed of mycolic acid, and please remember isoniazid inhibits the mycolic acid synthesis. It inhibits the cell wall synthesis. So this is regarding how it gets activated and what is its mechanism of action. Isoniazid produces certain important adverse effects. We need to know them. One very important and salient one is hepatitis, hepatocellular damage, and hepatic necrosis. You really need to worry about this. Let me tell you, most of the patients suffering from tuberculosis may be from lower socioeconomic status. They may be the patients suffering with HIV disease, and these might be malnourished patients. They might be alcoholic patients. So they are much more susceptible to get the liver damage, to get the hepatitis, the hepatocellular damage. And isoniazid has got this drawback that you need to keep a watch what's happening to the liver functions of your patient. Next important adverse effect with isoniazid is it depletes vitamin B6. I hope you remember what is vitamin B6. It's pyridoxine. INH depletes or utilizes vitamin B6. And as you know, vitamin B6 is required for the functioning of the nerves. So when B6 gets depleted, the patient can get peripheral neuropathy. So B6 depletion leading to peripheral neuropathy, second important adverse effect of isoniazid. Thirdly, it can precipitate hemolysis or bleeding in patients suffering with or patients having glucose 6-phosphate dehydrogenase deficiency, and it can lead to anemia. That's the next adverse effect of isoniazid. Isoniazid is known to precipitate SLE-like syndrome, systemic lupus erythematosus-like syndrome. The picture in the patient looks like SLE and the patient has skin rash. So that's the next adverse effect of INH, SLE-like syndrome. And lastly, isoniazid is known to produce hyperpyrexia, the temperature balance irregulation. And this is why the patient can get pyrexia, that's fever. INH is known to elevate the mood, so it can precipitate psychosis, or it can produce the significant symptoms in patients suffering with psychosis. And next, INH is known to lower the seizure threshold, and this is why the patients with epilepsy, you have to be careful. The seizures can get precipitated in a patient with epilepsy. What's the reason of these seizures? Let me tell you one important thing. INH is going to the central nervous system. It's crossing the blood-brain barrier. It is going to the central nervous system. Just now we said it depletes vitamin B6. So let me tell you, vitamin B6 works as a cofactor in the central nervous system. It works as a cofactor for various reactions, and it works as a cofactor in the GABA glutamate system. So if B6 is depleted, the result is more amount of glutamate and less amount of GABA, and this is the reason of getting seizures, or this is the reason of decrease in the seizure threshold with INH. Does it happen in each and every patient? No. I'm talking about a rare thing which can happen if the patient takes INH in a large dose. Sometimes it could happen that the patient has missed the doses for say 1 week, and to catch up, the patient takes 7 tablets, 8 tablets at a time, and then what you expect is the B6 depletion in the central nervous system, leading to the imbalance between the GABA and glutamate, and this patient can come with seizures. So on this page, most important one is liver damage, INH, and I described to you how the patient with tuberculosis is more susceptible to this hepatitis and hepatocellular damage. Next, B6 depletion leading to peripheral neuropathy. Next, SLE-like syndrome, then pyrexia, psychosis, and seizures. If you don't want to remember too many things from the INH adverse effect, I have a trick for this. You need to remember hepatitis and liver damage. There's no option for it. And after that, remember 3 P's. The first P is peripheral neuropathy. The second P is pyrexia. And the third P is psychosis. So when you think of INH, say liver damage and 3 P's. Peripheral neuropathy, pyrexia, and psychosis. This will make you feel INH adverse effects are comparatively easy. Let's go to the next slide. There is HMES inhibition, that's cytochrome P450 or hepatic microsomal enzyme system inhibition by INH. And this is significant if the patient is also receiving phenytoin. So isoniazid is going to inhibit the breakdown of certain drugs, for example phenytoin, and then phenytoin would accumulate and there are more chances of phenytoin toxicity. Next important characteristic as far as the kinetics of INH is concerned, INH follows acetylation polymorphism. There is genetic polymorphism as far as metabolism of INH is concerned. Please remember, isoniazid is acetylated inside the body. It's an acetylation reaction by the enzyme N-acetyl transferase. And amongst the human beings, there can be individuals who metabolize INH slow, or some others who metabolize INH comparatively rapidly or comparatively fast. So, by genetic polymorphism, you got few individuals who are called as slow acetylators, and in whom the half-life of INH is 3 hours. So what's going to happen is, in these patients, isoniazid is not going to be metabolized rapidly, is going to be slowly acetylated, and this is why the drug is going to accumulate and the drug is likely to lead to toxicity. What toxicity is expected? You expect to have SLE-like syndrome, you expect to have neuropathy, of course, and in few patients, bladder cancer has been reported. Slow acetylators are the persons who are going to metabolize INH slow, and there are 50% blacks and whites in United States and amongst the Europeans who can be slow acetylators. The rest of the population will be fast acetylator, and they metabolize INH fast, and the INH gets metabolized, or its half-life becomes just 1 hour. Who are these individuals? You get fast acetylators more in some particular populations, that's Japanese population, Native Americans, Eskimos and Indians. You could get fast acetylators. So slow acetylators and fast acetylators is an important issue as far as the INH pharmacokinetics is concerned. Let's move on with INH further to know what's the mechanism of resistance. There is 2 types of resistance known to INH. One is called low level resistance and the second one is called high level resistance. Low level resistance is quite common, and it happens due to the change in INHA gene. I small n small h is just nothing but isoniazid. INHA gene is the name of the gene. Because of the change in the INHA gene, the low level resistance happens and is quite common, and this INHA gene encodes NADH dependent acyl carrier protein reductase. We saw it has to go and bind with certain areas, and one of the areas was the acyl carrier protein. So INHA gene is encoding for the acyl carrier protein reductase, and this is how the low level resistance can be acquired by the microorganism. The high level resistance is rare, and this high level resistance happens due to mutation or deletion of the CAT-G gene. Do you remember what's this CAT-G gene? INH has to get activated by the catalase peroxidase system, and this catalase peroxidase system is encoded by the CAT-G gene. So there may be a change in the system which is going to activate INH, and then it can lead to high level resistance. This is quite rare, but there may be a mutation or deletion of the CAT-G gene. Let's move further again with isoniazid to remember that B6 or pyridoxine should be given accompanying INH treatment, just 5 to 10 milligrams every day for prevention of peripheral neuropathy. If the patient already has a deficiency state because it depletes B6, then you need to give a higher dose, that's 25 to 100 milligrams every day. You have to monitor the liver functions with isoniazid. Please remember, do not take too many tablets to catch up the missed doses. You'll have to give this particular instructions to your patient. By chance, if you miss the dose today, don't try to take 2 tablets, or if you miss the doses for 3 or 4 days, don't try to take 4 or 5 tablets all of a sudden to catch up, because it can lead to toxicity. Next one is there are interactions of INH due to the inhibition of hepatic microsomal enzyme system or cytochrome P450 enzyme system, because INH is a potent inhibitor of hepatic microsomal enzyme system. So with this, we come to the end of this particular session on which we started discussing tuberculosis. We tried to know about the various drugs, and we discussed isoniazid, a very important anti-tuberculosis agent, in details. I am sure you enjoyed this session, and you'll get to hear about other anti-tuberculosis agents on a new session. Thank you so much.